So now next, we will go to the next AIS, Dr. E.V. Srinivasan Award for this year, which is going to be bestowed on Dr. Rohit Khanna sir, who is the Network Director for the L.V. Prasad Eye Institute in Hyderabad, and is going to be speaking to us on so he's going to speaking to us about his experience in this field. Thank you.
Good morning, everyone. And at the outset, I would like to thank the organizers for bestowing me with this honor. And also, I would like to thank everyone on my team, because I was told to speak about my journey in community AI health, and my journey is not possible without my team being there. And also would like to thank Dr. Rao, because if his vision is not there and the team is not there, I think this would have not been possible. So thank you, Dr. Rao, for having that vision. And thanks to my entire team. And this lecture is about the entire journey of public health at L.V. Prasad Eye Institute, what's happening and what's going to happen. And it's dedicated to my entire team members. May I have the slides, please? Yeah. Yeah, so I was going through the biography of E.V. Srinivasan, and I was so surprised to see and so astonished that at the age of 80, till he left this world, he was still operating a detachment surgery. And the kind of personality he was, I think it's very difficult to find this kind of people at this, in this era. So, looking at the global figures, this was the report which came from the World Report on Vision from the WHO, came with these figures that there are 1.1 billion people require eye care and 90 million children require eye care, and the entire cost of vision loss is 411 billion. And despite the decrease in prevalence of blindness globally, still the absolute numbers were increasing because the aging population is increasing. So we are not able to catch up with the absolute numbers. Though we are doing good in terms of reducing the prevalence of blindness, but we are not going good in terms of reducing the numbers. So if we go with that rate, I think we are not going to achieve our target even till 2050. So there is some accelerated efforts have to be done in that area. And the major causes being, these are cataract, uncorrected refractive error, corneal scars, glaucoma, DR, and childhood blindness. And also the World Report on Vision stated that the eye conditions are more common in people living in rural areas with low economic status, women. These are basically the vulnerable group which we have to target if we want to deliver equity and achieve our goal for reducing the prevalence as well as the absolute number for visual impairment. And they also came with there are modifiable risk factors and non-modifiable. So there was a role of prevention in terms of acting on the modifiable risk factors, though non-modifiable at this stage we can't do anything much, but later on probably we may have some solutions for that in the future also. Coming to India, India has a very good record in terms of reducing the prevalence of blind, and what Prashant showed that the number of cataract surgeries we are doing from 1.2 to 8.5 million. And I think this was one of the reasons which led us to a significant reduction in prevalence of blindness. And recent data which came into 2020 was like showing 0.36, but there are still a lot of things, a lot of gaps in that, and we still have to achieve a lot. The overall numbers in India, because it's a big population, 1.4 billion, the total number of people who require eye care is 275 million, almost 1/4 of the country require eye care. And the total cost, we published this paper 2 years back where we found that the total cost of the blindness and visual impairment in India is 1.2 trillion INR or 54 billion US dollars. So that is the amount of money which is being required to spend for reducing blindness in visual impairment and blindness. And even though we have significant reduction in blindness, we have multiple challenges that we are not able to reach places, we are not able to provide good comprehensive eye care, the quality is quite variability in quality, the human resource skills are quite variable. We don't have very good models, very few good models are there, but still we require many more like that. And the role of technology is coming up, but still it's still very patchy. And we also have data in very, very sparse population, like we have very few states we have data, but right now we don't have data, enough data from many of the states in the country. So coming to what we did at L.V. Prasad Eye Institute, I'll just give you a brief journey of what happened at the public health in L.V. Prasad Eye Institute. So this is the eye care model which we have developed, which is a pyramidal eye care model, which is covering almost 310 centers as of now, including primary, secondary, tertiary, and center of excellence. And it's all based on the principles of 5 values and 10 core areas, functional areas. So these all areas are interlinked with each other. Without each functional area cannot do anything without the other functional area. So everybody is interlinked. It's like a corneal mosaic where you cannot have one area in isolation. And the entire eye health pyramid is not came out just from thought of anybody, but it was like basically based on a pure evidence from Andhra Pradesh eye disease study. We showed that uncorrected refractive error is also a major problem, and which led to development of primary eye care, which is vision center. So at the bottom of pyramid, we have the vision health guardian, which takes care of eye health of 5,000 population. And then we have at primary level, we have a vision technician, which is who is a high school graduate trained for 1 year, an internship of 1 year, and he's handling the entire primary eye care center, which is taking care of 50,000 population. This is a typical vision center where they do a typical, whatever you'd see in ophthalmology outpatient clinic, they do all the procedures, which includes refraction, slit lamp, dispensing of glasses, intraocular pressure, and all that, and even teleophthalmology. What we found was, a decade back, what we found was like, they were able to pick up all the conditions, but what we saw that they were not able to pick up glaucoma and retinal conditions, which like they were missing almost 1/3 to 1/4 of, only they were picking 1/3 to 1/4 of corneal glaucoma and retinal conditions, basically posterior segment conditions. So based on that data, we designed a study which is called L.V. Prasad Eye Institute Glaucoma Epidemiological and Molecular Genetics Study. And based on this study finding, what we found was 2 devices which came out significant, which can increase the sensitivity and specificity of this technician to pick up eye problem, which was non-mediatic fundus camera and FDT. But in terms of cost effectiveness, we felt that non-mediatic fundus camera were more effective. So we shifted to non-mediatic fundus camera. That is how futuristic or new generation vision centers were born. That's also all based on evidence. It's not like we just want to put cameras in this center. So we looked at whether is it making a difference in terms of providing care, and this is what we saw. There is a significant difference in terms of patient travel time was reduced. You can pick up many posterior segment conditions. So from 30% sensitivity, it went to 70%. Still, there are gaps, but I think we are still much better than what we were previously. And also, we looked at, so now we have, in India, we have a lot of people used to tell, why don't you do camps? Why don't you do outreach programs kind of things and all? Why you have vision centers and all? So we looked at all the things. What's the long-term benefit of having a vision center versus a camp, versus a school screening program, and versus a door-to-door screening program? So these were the different modalities of finding patients in the community. And the entire country is doing eye camps. Still, many of the places we see eye camps. But what we found, eye camps, this is a paper we published in the Lancet Regional Southeast Asia, where we found that eye camps, if you do eye camps, you have a very short-term gain. The red dotted line shows that if you do eye camp, you have quick results, you finish off. But if you do a vision center, which is this blue top line, it's a sustained effort for a long period, and it's more cost-effective. So what we published was a vision center model over a long period of time is more sustainable, more effective, and cost-effective than a eye camp approach. Eye camp approach can give you one-time intervention, give one-time results, but if you want to sustain the effect and have connection with the community, I think vision center is the way to go forward. Then comes the service center, where we have a secondary care center, where we have an ophthalmologist and a team of 25 which take care of entire comprehensive eye care, and almost 95 to 98% of eye health problems can be dealt at this level, and people need not travel to higher level of care. Again, there was a paper from European group which came out that cefuroxime reduces the risk of endophthalmitis, and there was a significant reduction, but it was very expensive. So the question was, should we give cefuroxime to all patients? The cost was going very high. In the meanwhile, we had moxifloxacin, which came into market, and which was 10 times much cheaper than cefuroxime. And to see which is more effective compared to both in terms of cost and effectiveness, We did a study in all the centers where centers were randomized to ciprofloxacin versus moxi group. And what we found that in the moxi group, the reduction of infection was 74%, and in terms of ciprofloxacin, it was 66%. There was no difference in terms of effectiveness, but cost was 10 times lower, so 10 times lower. So we shifted to moxifloxacin across our network. In terms of even coronary infections, what Prashant was alluding about, that we see a lot of infections, and if you don't take care of infection at doorstep, I think the more you delay, the more chances of the recovery is slower. So how do we pick up whether it's a fungal? So what we thought was the doctors sitting in the secondary care in the rural areas should be able to pick up at least fungal and non-fungal, and we decided to train them in KOH mounting, and they started using KOH to say fungal and non-fungal. And subsequently, later on, we also started using tryptophan blue dye. So tryptophan blue dye was more useful in terms of isolating the fungal hyphae, and the doctors were able to treat the patient based on the KOH and using tryptophan blue, whether it's fungal or non-fungal. And this paper we published in BJO. And also, as I was saying, that we also looked at our data that what kind of people who don't, ulcers which don't heal, if they don't present to us within 48 hours, the chances of recovery are low as compared to they present to us within 48 hours. So earlier you treat, the better it is. And I think we all know now what this was also published in Lancet Regional Southeast Asia Journal. And coming to teleophthalmology, I think that's now, it's a very, people are going into that area. And we have teleophthalmology across all the primary care centers where we looked at enter segment, as well as pick up many posterior segment conditions which were not picked up in the initial part. And we also have a system of referral where we highlight the referral as red, yellow, and green. The red are emergency referral. That means they have to be tracked so that the emergency can be taken care at faster rate. We have innovation devices where you can even, what Prashant was showing, that they can take a picture of a transplant and send it to you. And we have now innovation devices which are also in our primary care centers. We had Tapas Ranjan Padi, one of our colleague in Bhubaneswar, is also doing real-time tele-ROP, which is again one of the model for ROP screening in the rural areas. And then now our faculty who is in tertiary centers are traveling to secondary care to provide specialty care. So why do we need that 5% patients also to come to tertiary level and they have to travel so long distance? We were seeing there were dropout of like 30-40%. To reduce that dropout, we started specialty care at the secondary care. And one of the example is corneal transplant. What Prashant was showing that when we started doing corneal transplant in the rural areas, the outcomes were better, the follow-up care was better. So probably I think that's the way to go, the transplant, corneal transplant at the doorstep. The retina care, and then we have also, many of the centers, we have diagnostic van, because putting all this expensive equipment like OCT and fundus cameras and other devices in each center is quite expensive. So can it be shared between different centers? So we have a diagnostic van which goes from center to center, and probably the equipment are shared between 5 to 6 centers, so that the diagnostic equipment, so the specialty visit and the diagnostic equipment van is the coordination in such a way that when the people travel to, the faculty travel to secondary care, that time the van also goes there so that they can do all the investigation and do treatment at the doorstep. In the pandemic time, we started home care services where elderly and disabled people were not able to access care. So this is the home care services we started, and we published the first concept paper also at that time. In terms of capacity building, we have done capacity building of nearly 250 organizations across the world. And in terms of advocacy, we are active at state level, at global level, working with WHO and IPB in different capacities. And also we were involved in developing the regional action plan for Southeast Asia for 2022 to 2030. In terms of research impact, we have clearly defined the verticals which we'll work on. So these are verticals which are on vulnerable population and health system research. So our entire focus of research is in these areas, and we usually don't deviate from these areas. These are our focus areas of research. And in terms of, these are basically key focus areas in which vulnerable population, which includes children, elderly, tribal, and occupational. And in health system, we do rapid assessment studies, operational research, and all. In terms of impact, I'll just give you one last case study of one of the center which we started more than 25, now it is 28, 29 years old, where we started, when we started, we did the Andhra Pradesh IDC study, and we found the prevalence of blindness was visual impairment was nearly 50%. That means every second person had some kind of visual impairment, and we are proud to say that with all our interventions, there is no eye care available in that area even now, and the prevalence of visual impairment has dropped to 16% in 50 years and above. In terms of vision center impact, I think we were looking at universal eye health is another area which we are focusing upon, so that each and every person in the house get care. And we looked at one of the vision center which has group of vision center which has finished 10 years. And what we found that the entire population, when we looked at, they have covered is like in 10 years they could cover only 45% of the population. Still that even after 10 years vision center being there, we were not able to reach. So now we have started a campaign where we are going from each and every door to door in that population, so that in 5 years we complete the entire population, so that everybody has eye care service given at their doorstep. I would like to, at the end, I would acknowledge my entire team, without without whom this work is not possible. And it's, I would like to acknowledge the entire team members, including those who are here and those who are not here. Thank you.